Okay. Good evening, everyone. I welcome everyone for today's class. I request Einass to start off the remaining for the portions for wound management.
Yes, sir. Good evening. The in the last class, the factor wound healing, the process of wound healing, factors of wound healing, and like uh, hypertrophied scar and keloid scar were discussed. Now, going on to acute wound management. Uh, so, usually, in uh, a wound basically is a disruption in the normal structure, and to ensure proper healing we need to ensure that the healing tissue is well vascularized, and there should not be any devitalized tissue, and no infection, and appropriate hydration should be ensured. So in wound healing should ensure that there is a process which is facilitating elimination of the dead space, preventing bacterial overgrowth, and ensuring that there is a proper fluid management. In the initial care, wound that have devitalized tissue or contamination, residual foreign material, you will generally benefit from cleaning and debridement prior to further wound management. And in this irrigation, that is cleansing of the wound, is a very important step, which will enable us to decrease the bacterial load and remove all the loose loose material which is present. And there is no data per se available for irrigations and additive, and in addition there is no added benefit. Usually the most commonly used irrigant is that of isotonic normal saline, and there is no significant difference which is seen in by using any other antiseptic solutions like chlorhexidine or sodium hypochlorite. And it is generally not necessary because these additives have minimal action against bacteria and may sometimes also impede wound healing. uh, the other thing that we look into is the low versus high pressure irrigation pressure system, wherein low pressure will involve giving less than 15 pounds per square, and high pressure is like a pulsed lavage system. And low in most of the cases we use the low pressure irrigation system, which is adequate for removal of the material, but high pressure irrigators can be used in case of very highly contaminated or dirty wounds. High pressure comes with a drawback of local tissue damage and tissue, it can increase tissue edema. But it usually, in case of highly contaminated wound, this risk is outweighed by like the need for reducing the bacterial load. The second step which comes is the debridement, wherein surgical debridement is appropriate for removing the necrotic tissue area. And here we prefer to go ahead with sharp debridement, because this will first it stimulates the contraction, deficit contraction, and it also promotes wound epithelialization. In case patients who are not in case patients who are not like suitable for surgical debridement, or pain control sometimes may be inadequate, herein we can consider enzymatic debridement or like biological debridement. These are some of the agents which are used for enzymatic debridement, which will involve applying these exogenous agents to the wound. Many, but basically there are no results which are available which demonstrate the superiority of any specific agent. Ulcer healing rates are also not improved by the application of topical agent, but collagenase can promote endothelial cell and keratinocyte migration, and thereby we have angiogenesis and epithelialization, which can which is a that is how the collagenase functions. More than being a debridement agent, it is helping in promoting wound healing. Uh, and in the other aspect, there are biologics which will involve using medical maggots, that is the green bottlefly or the which is used. And the larvae of these will secrete proteolytic enzymes, which basically liquefies the necrotic tissue. And visible and further leaves the healthy tissue intact. Maggot therapy can be used for pressure ulcers in case where there is venous ulceration, and in also in diabetic foot ulcers. However, the main disadvantage of maggot therapy is related to the negative perception about its use by the patient and the staff. Going to
Wait a minute.
Yes,
See
sir.
what are the circumstances which preclude wound debridement? This is where will you think, oh God, I can't do the debridement here?
Uh, so like if the patient is not fit for giving any in take for to be taken up under anesthesia, sir, in those cases, and the patient will have intensive pain, sir, like, and pain management won't be adequate in those cases, sir.
No, but you can do regional blocks, no? You in such patients where either spinal is also contraindicated, general anesthesia and spinal anesthesia is contraindicated, you can still do regional blocks and do the debridement, because I think ultimately, the patient will not improve till the necrotic material and the pus and other things are all debrided. Till then, the patient will not improve.
Yes, sir. So, like, if there is severe like ischemia in the leg or like that, sir. Uh,
So if severe ischemia is there, then how can enzymatic or biologic agents help?
I'll, yes, sir.
See, whenever there is severe ischemia, your first focus should be to improve the blood circulation. Then you do the debridement. You do an angioplasty or stenting of the vessel and improve the inflow into the limb.
Yes,
Usually, because ischemia doesn't happen in the trunks, because trunk is generally well supplied. So, if at all you're talking about ischemia of lower limbs, usually in that situation, the debridement has to be deferred till such time that you improve the vascularity. So, you do the dressing and improve the inflow by doing an angioplasty or stent, and then 24 hours later you do the debridement. So I think alternative methods have, I think, very little, shall we say, indication for going for it. Niranjan?
Yes, sir, I agree. And
Something like add-ons we can
whatever,
sell, sir.
Huh?
Additional to surgical debridement,
we
maybe like
don't have the first of all, we don't have the infrastructure for that maggot therapy. If it is available, maybe we can try them, but I don't think there is enough infrastructure or enough centers where the medical maggots, with what they call them, like medical grade maggots, that systematic, very, I think, select few places, I don't know, I'm not even aware where in Bangalore there it's available. Maybe one or two places it might be there. You have any idea, sir?
No, I don't. I don't know where you get them. I think if, for example, in a chronic venous ulcer, where you think debridement may not be necessary, you can do maggot therapy and then do 4-layer bandaging after the all the necrotic material or the this one is taken away. I think that it's very selective indication for maggot therapy. I have not heard of enzymatic therapy being useful in any situation, because I think debridement has to be the cornerstone of management of wounds. Okay, carry on, ma.
um, going to the dressings, wound dressings, uh, an ideal dressing is considered to be that, or like, it should have the following characteristics. That is, it should absorb all of the excessive wound fluid, and while maintaining a moist environment, protect the wound from further mechanical damage, prevent any sort of bacterial invasion. It should also like eliminate dead space. It should come to the wound shape, and should not macerate the surrounding viable tissue. In addition, it should also minimize edema through compression, and it should not cause any hypersensitivity reaction. In addition, it should be readily available, have a long shelf life, and based on its absorptive properties, it should also enable minimal dressing change. And in addition, there can also be one factor that a transparent dressing material, which will aid in monitoring the wound appearance without disrupting the dressing, is also another factor. Uh, Wound healing is the most successful in a moist, clean, and warm environment. And if we take a moist occlusive dressing, that will allow us the rate of epithelialization nearly doubles in those conditions. The mechanism behind that is that it provides an acidic pH and a low oxygen tension, which promotes fibroblast growth and granulation tissue formation. Uh, like but in conditions where there is a lot of production of exudate, in these conditions we need to consider a placement of a purely occlusive dressing, so that uh, it aids in preventing bacterial overgrowth. So in broad categorization terms, the dressings can be categorized into open dressings, semi-open dressings, and semi-occlusive dressing, wherein open dressings will primarily include the gauze, like the gauze bandages, which are or thicker absorbent pads, which could be used. Semi-open dressings consist of fine mesh, which is impregnated with like paraffin wax or petroleum, which could be in the form of xerofoam or gelonet. And in the semi-open dressing, they basically have a layer of secondary dressing in the form of an absorbent gauze, and a third layer, which is an adhesive layer. And the semi-occlusive dressings include they could be polymer films, which are transparent sheets, and basically they are permeable to oxygen, but they are impermeable to large molecules including protein and bacteria. And these can be available, like these include tegaderm and biocclusive dressings. uh, Further, the broader classification also includes non-adherent fabrics, occlusive dressings, and absorptive dressings, as well as ointment and cream. In non-adherent dressings, again, it is includes the fine mesh gauze, which is the primary function being that of protection, and this will include your like the scarlet red and zero foam gauze, which is available. In absorptive dressings, you have the gauze and foam. Again, foam, which comes in the form of hydrophobic polyurethane sheets, and the function of this is to protection and absorption of the exudate. Uh, this is not effective when the disadvantages of that is that it is not effective when saturated, and advantage is that it is comfortable, it can conform to wounds, and it is easily removable by cleansing. And
No, Einass, you said hydrophobic, right?
yes, sir.
Then how will it absorb the pus and everything if it is hydrophobic?
So it is because of polyurethane, sir, which helps in the absorption of exudative material, sir.
No, but you said it's hydrophobic. Most of the pus and everything is liquid based only, water based, right?
Yes, sir. Yes,
So
sir.
if it is hydrophobic, it shouldn't absorb it.
Yes, sir. Like I,
What in your opinion is ideal dressing? You quoted all that characteristics of ideal dressing. Is there anything that we can use, virtually in all circumstances?
uh, sir, like these hydrofiber dressings are like I just went through the papers, sir, which
Hmm.
telling like the hydrofiber dressings, like foam dressings, which are there, they are good for absorption, and like based on the meta-analysis, these are appearing to be superior in comparison to other dressings, sir. Like a wound healing is the fiber dressings have a wound healing of 82 to 87%, even the foam dressings around 80%. And the second one which came were the alginate dressings, sir, which was around 70%, sir. But per se, there was no one fixed dressing which was given. So, like they kept on saying that it will change based on patients and like the type of wound which is there. But these three were the dressings which came up.
Yeah.
Like,
So yes, sir.
yes, Niranjan. Yeah.
Just wanted to add to that. That's what. So there is no ideal dressing available as of now in the market. The only proven like with little evidence is calcium alginate hydrofiber dressings, as Ainas was mentioning. That is what I just wanted to add to that. With
Yeah.
silver. Yeah.
Okay, carry on, ma.
Yes, sir. The third criteria being occlusive dressings, which includes film. Again, these are polyurethane membrane with adhesive on one side, and they help in moisture retention. They form a protective barrier against bacteria as well. These include your tegadum and bio-occlusive dressing. Uh, the occlusive dressings will also include hydrocolloid, which will contain like gelatin, pectin, and carboxymethyl cellulose. Again, the mechanism is the same. Alginates, these are cellulose like polysaccharides, and they have an occlusive environment. They calcium alginate. There is a conversion of calcium alginate to soluble like sodium salt once it comes in contact with the wound exudate, and therefore there's a hydrophilic gel which is formed. The third being hydrogels. Again, they have the same mechanism where they have a little water absorption. In addition, they have rehydrating agents in them, which helps in little water absorption. Homographs and xenographs come in the biologics category of wherein homographs are derived from humans and xenographs are interspecies graft. And temporary, these are the advantage of the disadvantage is that these are all temporary dressings, and these will be rejected if left on the wound for an extended period of time. And the ointments and creams will include the antibacterial ointments, which will have different components, which could be acetic acid or bactericin, and even neospore polymyxin B as well. In these, they are basically you lubricate. They are lubricating the wound surface, and they can have an antibacterial activity which can last for 12 hours. These are the dressing materials again, which were quoted, which were the alginates foams. Honey is also used in rehydrating the wound bed. Hydrocolloids, hydrogels, iodine, which is shown to have some antimicrobial action, and other than that, there are odor control like activated charcoal, which is used in odor absorption. Silver, polyurethane film again, which helps in moisture control. And like that's all for the types of dressing materials. Uh, Going to adjuvant therapies, there is a negative pressure wound therapy and hyperbaric oxygen therapy. Uh, Negative pressure wound therapy, this is basically vacuum assisted wound closure. And herein we are there's a system which is continuously or intermittently applying subatmospheric pressure, and this in turn provides a positive pressure to the surface of a wound. The device and placement, this usually involves using an open pore polyurethane foam sponge, and along with that, a fluid collection system and a suction pump. The foam sponge needs to be trimmed to fit the size of that open wound which is present, and it is placed into the wound cavity. And we should take care that the foam does not extend beyond that margin, and then the foam is secured beneath an adhesive sheet, and then you place in a suction port. This port is connected to the portable pump, which applies a pressure ranging between -50 to -175 uh, of mercury, which could be in continuous faction or intermittent faction. And this pressure also reduces the volume of the foam by 80%. The dressing changes that are involved are basically in a setting of between 48 to 120 hours. That is ranging to approximately 5 days. And the here the mechanism of action includes in two ways. One is the direct effect, and the other is an indirect effect. In direct effect, you have a semi-permeable dressing, which is maintaining a moist and warm environment, which is allowing wound healing. And this closed generated system is generating a pressure gradient, which is present between the wound and the suction, and thereby there is a promotion of like fluid transport from the wound bed and the interstitial space, thereby reducing wound edema. Then fluid is removed also because of application of the pressure, and the porous structure of the foam allows even distribution of the pressure throughout the wound, and thereby positive pressure is applied to the wound surface, which varies between 5 to 10 mm. And the foam also contracts, so the foam keeps on contracting, so the edges of the wound will get approximate keep on coming closer, like there's drawing of the edges which is present. And this also further helps in the process of healing. The indirect effect includes alteration in blood flow. So there are various studies which are telling that this negative pressure therapy is going to initially cause ischemia. There is going to be relative ischemia in the initial stages. This will stimulate the release of growth factors and vasoactive agents, which will result in increased granulation tissue formation. The second will be reducing the systemic inflammatory response, that is your interleukins and monocytes. And again, this is not proved, but some papers say that there can be a reduction in the bacterial burden as well while applying this negative pressure therapy. The indications will include like following surgical debridement in case of necrotizing infection, pressure ulcers, or diabetic foot ulcers as well. It can also be used in an open abdomen in orthopedic cases, and even in reconstructive surgeries post burns and skin graft. Uh, Again, like the advantages are, as mentioned, that as it is being changed every 5 days, so usually this is less tedious for the patient, and less painful as well. And the disadvantage of it being the need for carrying the portable pump, and like a relative disadvantage which can be considered is that it is relatively expensive. uh, the absolute contraindications for applying these negative pressure wound therapy include in cases where the vital organs are exposed, which could be your blood vessels or any or exposed organs as well. These are the conditions where you don't apply these wound therapy. And in case of presence of malignant tissue, again in these cases also you are not we're not supposed to apply negative pressure therapy. And the relative contraindications can be ischemic wounds, ongoing infection, and if there is a presence of a fragile skin as well. Uh, in last, complications are bleeding that can happen during the removal of the foam if it is firmly adherent to the granulation tissue. Uh, Rarely, but infection can happen, and the form again a rare complication, that is the formation of an enterocutaneous fistula. This is the negative pressure wound therapy, which is showing the foam, the adhesive sheet above, and the suction port which is present above. Uh, I'll go to hyperbaric oxygen chamber now.
Right. Any questions or comments, students, on negative pressure?
No, sir.
No comments.
Einass,
Do you know?
any specific reason why malignance? Why do we not use negative pressure wound therapy in a malignant?
Uh, First is in like there will be like this subatmospheric pressure which we are creating. So there'll be growth of that malignant tissue will be promoted, and the malignant tissue is also very friable. So that is more prone to bleeding as well.
Bleeding. Yeah.
To avoid
Okay.
in those cases.
Does anyone know where the first negative pressure wound dressing was used?
No, sir.
It was used in post radiotherapy abdominoperineal resection wounds, where because of the radiotherapy there was delayed wound healing and the pelvis would not close. So we used think I think it's probably United Kingdom which used the negative pressure wound therapy first, and subsequently after that was successful, I think they started using it for diabetic wounds and also for bad peritonitis abdominal wounds which were left open and such situations. So I think it was the pelvic wounds post radiotherapy, long course radiotherapy, and AP resections.
Sir, regarding this infection, sir, if there is an infection, which can we do this negative section, sir? Is it something
No,
like a
no,
relative
it is not.
contraindication?
It is not a contraindication at all. In fact, it is better if you do it.
Okay.
I think as you
What is
see,
what is your question, Vinod? In like you mean without the debridement you're asking you
Yes, sir. Yes,
whether
sir.
you can
Without
straight away
debridement.
apply
Without.
or
Yes, sir. Without debridement.
always
you
never
can
never
apply, but always better debride and then. But in
never.
certain situations where patient is very sick, you cannot. Like some patient people like bed sores, where patients are bedridden and they cannot take you to them to OT or do anything. In very special situations, you directly apply back. But in majority or 99% of the situations, you ideally do debridement and then apply back.
Okay.
Sir,
Yeah, yeah,
your opinion?
exactly. Okay.
So I'll go to the next topic, sir.
Yeah.
Yeah.
Going to hyperbaric oxygen chamber therapy. Here, basically, here the benefits of HBO is because of the by the gas concentration, volume, and pressure system. It is associated firstly with increased oxygen delivery, and when in when a patient is placed in a hyperbaric oxygen chamber, this HBO system delivers like nearly at a level of 3 atmospheric pressure, and it gives a dissolved oxygen content of 6 ml per deciliter, whereas when we consider like at normal sea level, the amount of oxygen content will be ranging between zero point 0.3 to 1.5 ml. And so this basically this the ability of HBO to augment the oxygen content, and this helps in meeting the tissue oxygen requirements, and therefore helps in it helps in cases where there are tissue hypoxia. Second, it reduces the gas bubble size. Usually HBO is used in conditions wherein you have decompression sickness or gas embolism, or where there is tissue hypoxia. Herein, when we consider decompression sickness or gas embolism, there are gas bubbles which are obstructing the blood flow. Use of hyperbaric therapy, again at 3 atmospheric pressure, the bubble volume decreases to two-thirds of the size, and further there will be dissolution which will be accomplished. And the third one is antagonism of carbon monoxide. So, usually, carbon monoxide has a higher affinity, like 200 to 250 times greater than that of oxygen. And in a hyperbaric chamber, the half-life of CO, which is 4 to 6 hours, is reduced to nearly 40 minutes in case of 100% HBO chamber. And
So you think hyperbaric oxygen and negative pressure are diametrically opposite? because you say there it causes relative hypoxia, which stimulates neovascularization and granulation tissue. Here you are delivering excessive oxygen.
Is sir, that is like in a transient phase where there is a hypoxia and ischemia, sir, which is promoting granulation tissue, sir. And yes, sir, like that's what I understand.
Okay, carry on.
Uh, and again, there'll be improved wound healing in both acute and chronic injuries, and in case of inflammation. This is mediated by the ROS, the free radicals, oxygen derived free radicals, and which are generated in the tissue. And this will aid in improving the wound healing. The technique involves there is a multi-place chamber. So basically, there is it enables us to allow close monitoring of critically ill patients, and the chamber pressure is maintained between 2.5 to 3 atmosphere, with the treatment time which can last between 45 to 300 minutes. This will depend upon what the indication is for giving the HBO therapy. And further, acute therapy like if it's an acute therapy, this will require 1 or 2 treatment sessions. And if there is a chronic medical condition, that warrants like giving up to 30 sessions. And hyperbaric therapy is administered with pressurized oxygen or air, and pressures exceeding like 2.8 to 3.0 atmosphere are used in these conditions. And like like you also have to monitor the patients to look out for complications of pulmonary or neurological toxicity needs to be looked out at. The absolute contraindication for hyperbaric oxygen therapy is pneumothorax, whereas relative contraindications can be like obstructive lung disease or a patient who has a seizure disorder, because there can be CNS toxicity from administration of high oxygen concentration. And patients also who are on like bleomycin, they are associated with pulmonary toxicity. So you avoid giving hyperbaric oxygen therapy. The second one is giving it in case of doxorubicin, which will induce cardiotoxicity. Complications can include middle ear trauma, which is seen in the incidence is around 2%. There can be sinus barotrauma, myopia, but this is usually reversible. Pulmonary toxicity and pulmonary barotrauma can occur. And yes, that's all. Like, and the indications which were covered, which was including decompression sickness, air embolism, carbon monoxide poisoning, and like acute thermal or traumatic injury.
What
Going to
about gas gangrene? Is it an indication for?
Yes, sir. Yes, sir. We can also, like in case of necrotizing fasciitis and gas gangrene, HBO is also shown to be useful in those cases as well, sir. Like Fournier's gangrene, clostridial gas gangrene, necrotizing fasciitis, all of these. After aggressive debridement, you can use HBO therapy. Mm.
You have no pictures of the HBO therapy?
No, sir, I didn't add the picture for HBO therapy, sir.
Ainas,
Yeah.
what does the meta-analysis say about hyperbaric oxygen? I know you mentioned
Sir,
very well the theory and all that. So practically, when will you use it? What does the meta-analysis suggest, or what is the recommendation for hyperbaric
uh,
oxygen?
like most of the papers in like for HBO, they are mainly focusing on decompression sickness only, sir. Like for like that scuba diving and all those patients, though
Hmm,
they will
hmm.
in only those cases. There is no
No, no, no. For our purpose, like
as
diabetic
of
foot wounds and all that. So, is there any role for hyperbaric oxygen, like common non-healing wounds or venous ulcers?
No, not for venous ulcers or this. There are studies conducted for Fournier's gangrene and necrotizing fasciitis, but the evidence is very low, sir.
Yeah, correct.
All the studies involves doing studies for 26 patients or 29 patients as of now, sir. Like that.
Yeah. Sir, your opinion, sir?
I don't have much experience with the hyperbaric oxygen. So I think I'll take whatever Einass says as the thing current
Yeah,
recommendation.
yeah. Because why I wanted to ask you was because there are people who are marketing hyperbaric oxygen as the some kind of a ultimate treatment for all sorts of wounds, especially diabetic foot wounds and all that.
Yeah,
So
yeah.
that's
No,
why I wanted to highlight that.
I
So
don't. Yeah, I don't think there is any conclusive proof that it makes any major difference. But maybe in patients with Clostridium infections, maybe in patients who have had debridement after necrotizing fasciitis, one or two episodes of hyperbaric oxygen may help. But I think maybe and what was the prime indication you said, ma?
Sir, decompression sickness, sir.
Those things definitely it will help, but not
yeah,
in other situations.
yeah,
I don't.
because it is being promoted as an alternative to debridement. Like
Ah,
gangrenous wounds and all that, you just give hyperbaric oxygen, it will be all right and all that. That's right.
I
So there is
think
very limited data.
each session how much they cost 50,000 to 1 lakh, I think.
5,000. It is not that much. It's around
Okay,
5 to 8,000 or something, but they keep on giving it for weeks together.
okay,
Like every day, you have to go for few minutes. You have to take that, keep this thing in the hyperbaric chamber.
okay.
And I've seen so many complications. Like they keep on discouraging debridement, and they say it'll become all right, all right, all right, and eventually they will lose the toe or the
Limb.
limb.
Hmm.
So it is definitely not an alternative to debridement, surgical debridement. It is one of the options available, but a very limited scientific data available, scientific literature available for our regular wounds. As Ainas mentioned, there is only good data only for those indications which Ainas mentioned.
Yeah. Okay.
And just an overview about the chronic wound management. In chronic wound management, firstly, it will involve clinical assessment, which wherein we look at the wound assessment. The parameters being seeing the vascularity and also involving investigations, which will include your routine investigations as well as the cultural and sensitivity to rule out any to ensure that appropriate antibiotics are given. Furthermore, nutritional screening to ensure that there is no malnutrition and glycemic control, because this is one of the most prime causes for wound to be for a chronic wound. These are the four factors that we look at. Uh, Further, the first step will be looking into the local care of the wound. This will involve like uh, odor control, which will involve it could be because of done by mechanical debridement, and this can also be reduced with the help of topical antimicrobial administrations, metronidazole can be administered. In addition, we can use dressing materials like mentioned, absorptive charcoal, which can be used. And some studies show that diluted acetic acid can also help in minimizing odor. Second is bleeding. We need to ensure that a non-adherent dressing is placed directly on the friable tissue so that there is a reduced bleeding and reduced pain associated with dressing change. Uh, the chronic wound that usually which are prone to oozing from the ulcer bed, which can be controlled with the use of topical hemostatic agents and sucralfate as well. And the third factor being pruritus. Itching is a common complaint associated with chronic wound, and this can be because of contact dry or wet skin dermatitis. So we need to ensure that there is proper moisture balance and protecting the skin which will help in reducing itching and skin irritation. And if necessary, topical corticosteroid creams can be applied. Exudate and pain has to be appropriately managed, wherein in cases of exudate, you will use absorptive dressings, which have to be placed to control the drainage and also ensure that the around the wound, the normal skin tissue should not get macerated. Again, going to the approach, the primary approach is the operative.
Just a minute, Ma.
Yes, sir.
While talking about whether is there any role for local insulin therapy in chronic wounds? Second is any role for PRPs?
Sir, I'm not sure
Study
about
your voice is breaking.
Huh?
Hello,
Huh?
your
Hello.
voice was breaking. We were not able to hear the second part.
For the role for local insulin and platelet-rich plasma dressing for chronic wounds.
Einass,
Sir, I'm not sure, sir. Like I read that the mechanism is like it is enhancing collagen synthesis, and it also helps in angiogenesis. So you can use it in diabetic foot and pressure ulcers. So like there are these topical insulin gels and insulin impregnated dressings, and they say that the healing time is reduced by 30 to 40%, sir. But I'm not sure how much it is like uh, like the efficacy, sir. I'm not sure about that, sir. Mm.
Anybody else? Nitya, Nikita, you have been very silent today. Are you there, Nikita? Hello?
Yes, sir.
You have
So
been
there
very
have been
silent.
studies.
Ah.
There have been studies, but there are no meta-analysis to comment, sir, about their statistical significance. They are proven to improve the wound healing, but how well they're useful is not
But
established yet, sir.
what is the likely mechanism of action of both insulin and platelet-rich plasma?
So it causes
Both
stimulates cell proliferation, sir. Like tissue regeneration by like local blood circulation is improved because of that, sir. Uh,
How will insulin cause all that?
the
Will,
insulin
will,
has the property like growth factor, sir. So it enhances the cell proliferation.
what about
no,
PRP?
it improves wound healing by regulating oxidative and inflammatory responses, basically.
Correct.
Insulin.
Yeah,
It basically decreases the levels of reactive oxygen species, so which
correct.
can cause deleterious effects on lipids, proteins, and DNA. So that is how the insulin acts.
Insulin. And platelet-rich plasma, platelet-derived growth factors will stimulate neovascularization and improve the vascularity of the wound, and also it will reduce the formation of exudate. So because that is being proven in virtually all circumstances, in chronic wounds, I don't know whether anyone has done studies on that. I think that is the homework for you guys, because in many other situations, PRP has been proven to be very good. Whether it is useful in chronic wounds, look at the literature. Homework.
Yes, sir.
Okay?
yes, sir.
Yes, sir.
Okay.
Sir, what about this topical injection, sir?
Topical
Injection
injection of
of
what?
what?
This metrogel.
No, you don't give
No, no,
injection.
no.
What you do is soak. See, soak the wound, we gauze with metrogel. That
Yes,
is
sir. Yes, sir. That's
as she said, it is mainly for odor control, because
okay.
the majority of the
Anaerobic
odor,
this thing bacteria.
yeah, the anaerobic bacteria, by it will what shall we say? It it will reduce the anaerobic bacterial load and hence reduce the odor. Whether it will promote wound healing is a moot point. I don't think it is proven.
There is no evidence to suggest it will promote wound healing. As sir said, it is mainly for odor control.
Okay, sir.
See,
Whenever there is like a suspicion of anaerobic.
See, there was a time when in England, at least, I don't know whether it was used here. There was after peritonitis, patients who had very severe peritonitis, you would, after you have done thorough debridement and washing out the abdominal cavity, they would wash and wash the cavity with the gentamicin, saline or metronidazole saline, and one is to try and reduce the post-operative wound, wound collection, abdominal interloop abscesses and abscesses in the peritoneal spaces, and also to prevent wound infection. I don't think there was any conclusive proof that it would do that. So I think that practice has been given up. So if you extrapolate that situation to chronic wounds, I know Metrogyl serves the purpose of reducing odor, but not necessarily to promote or stimulate wound healing.
Okay, sir.
Okay.
Einass, anything else?
No, sir, just like adjunctive therapies and wound coverage, which will involve using appropriate grafts, which could be split thickness, full thickness, or even localized tissue flaps and pedicle flaps.
Those are, I think, different. This thing.
Yes, sir. Yes,
Hello,
sir.
sir.
Huh?
That's
A different class.
Yeah,
Skin
that's
grafting and all is different type. Yeah.
yes, sir.
Yeah.
no, but I think Ainas, you should concentrate. Go back.
Yes, sir.
You actually went to go to the previous slide. And the previous slide before that, yeah. See, this vascular assessment has to be followed up by corrective action, because one of the reasons for chronic wound is ischemia. So you have to ensure that the ischemia's component is taken care of. So
Yes.
that will itself make the wound heal faster. Once the vascularity of the wound improves, then the wound will heal faster. So you have to take corrective action either by by stenting and angioplasties or even bypass grafts, which are nowadays used less and less. But nonetheless, chronic wound, one of the main reasons is ischemia. You have to correct the ischemia. So that will help to wound healing. So whenever you talk about this, when you have written, good thing is nutrition screening, vascular screening, very good, but you have to take corrective action, both in terms of nutritional improvement and also by improving the vascularity of the limb or the area which is in question.
Yes, sir. Yes.
So I think that probably will conclude the class.
Yeah. I think, anything else? Anyone else? Anything? Any doubts? Any points?
Praveen,
Nitya, Praveen.
after coming from Agra, either you have become 100% saturated with knowledge or you're not opening your mouth. What man, Praveen?
He's on duty. I think. I don't know whether he's there.
Okay.
He's there. Huh?
I think he's probably not there.
Nitya, Nikita.
Okay.
Any other doubts? Any comments?
Mhm. No, sir.
Final comments.
Einass has taken very extensive class, sir. Like she has done it very nicely, sir.
Yeah. Nikita. I don't know. Nikita is there? Not there?
She's there, sir.
Sir?
She's there. I don't know.
Why
Okay.
is she not
Sir,
on?
your final comment, sir.
Yeah, I think Ainas, you've done a good job. I think all the points were well made, but the same sort of problems persist. I think there are too many likes and things like that. So you need to try and address that, because as you go along, you should improve the presentation to such an extent that you know, minimize these, what shall we say, like or I mean, and things like that. Once in a while is fine, but it comes so very frequently. So you need to try and cut that out.
Yes.
Otherwise, good presentation, good material, and I think well prepared and well presented.
Yes, I agree with sir. I think if there are no more questions, I think we'll conclude. Well presented, Einass.
Good night.
Thank you, sir. Good night.
Good night, sir. Thank you, sir.
Yes, sir.